Good afternoon, and welcome to our CME program, Targeting the Drivers of IBD, Understanding and Incorporating Advanced Therapies into Clinical Practice. Here's our agenda for today. We are going to talk about understanding and targeting the cytokine drivers, using IL-23 inhibitors in clinical practice, and then we will also have time for your questions. I'm Sharon Dudley Brown. I'm a nurse practitioner at Johns Hopkins University in the IBD Center, and I'd like my other colleagues here to introduce themselves.
Hello, I'm Elizabeth Evans. I'm also a nurse practitioner, formerly of UC San Diego IBD Center, and now I'm in private practice at Perelman Clinic.
Hi, everybody. I'm Kim Orlick. I'm a physician assistant who practices out of Atlanta, Georgia, Atlanta Gastroenterology Associates, which is a partner practice of United Digestive. Really happy to be here.
Thank you. Our objectives for today: to describe the role of key cytokine pathways and their networks in the pathogenesis of IBD, to differentiate among the IL-23 inhibitors for IBD with regard to mechanism, clinical efficacy, and safety, and describe how mechanistic, clinical, and practical differences between therapies influence treatment selection for individual patients with IBD. Here's our accreditation statement. Here are our faculty disclosures. You will get an email after the program with instructions to collect your, claim your CE credits. So we will go ahead and get started, but I did want to give a big thank you to Johnson & Johnson for their grant support of this program. Thank you.
So we all made it to the last day. Thank you for coming to our presentation. So for the next few slides, we're going to go into a bit of the pathophysiology of inflammatory bowel disease and our medications that we're using. And I was worried that you would have seen these slides multiple times throughout our presentation, but it seems like this may be the first time you're seeing these. And so I'm excited to go through these with you. So when we think about our body's immune system, we have our skin, our mouth, and women, we have our vagina, and we have our gut. And about 70 to 80% of our immune system is in our small and large intestine. And it makes sense, right? Because if we were to, in caveman days, if we were to pick that berry and it was poisonous, we needed to have that defense mechanism. We also need to have those good bacteria that help us convert vitamins, and we need bacteria for digestion. And so we have this mixture of good bacteria, we have our defense bacteria, and we have this army that's primed if we need to protect ourselves. So inflammatory bowel disease comes from this dysregulation in our immune response. And I would have patients that would come in and would say, oh, I have IBD, I'm immune suppressed. In actuality, what they have is an overactive immune system. We understand that there are environmental factors such as smoking. There is a genetic susceptibility. We do see this, What we're understanding is that now there are microbial factors that play a role in how patients develop inflammatory bowel disease. So it's this disruption in this epithelial barrier. It's this defense mechanism, this lining of our large and small bowel. When there's this dysbiosis or this imbalance, this bacterial invasion happens, there's a breakthrough in that epithelial layer, and that's what targets the immune system, our army, to come to defense. Unfortunately, with inflammatory bowel disease, we aren't fighting a toxic bacteria. We aren't fighting a poisonous berry. Patients with IBD are fighting against themselves. So when we look at the pro-inflammatory cytokines that are involved with inflammatory bowel disease, think of it as sort of this perpetual cycle. IL-23 is an important player in this pathogenesis of inflammatory bowel disease. So we have these macrophages and the dendritic cells. Those are sort of our first reaction in the immune system. The macrophage then start building up these anti-cytokines. And these cytokines, you might recognize some of these names: IL-12, IL-23, TNF. That plays along a certain pathway, the Th2 cell pathway. I almost sort of think of this as like a whack-a-mole, right? You have multiple areas, multiple ways of an immune system. And as soon as you think you got one down, poof, another one comes up. And so this body is sort of playing whack-a-mole, if you're familiar with that game. So again, just to kind of show you, this IL-12/23 pathway is sort of the newest kid on the block, although it's not so new, but this is where we're going to talk about throughout this program and really highlight these medications that you may not be as familiar with. And so how do we know this? How do we know that TNF is an important cytokine? How do we know that IL-23 is an important cytokine as part of this immune pathway? We can see this. And on the TNF slide, you can see where there's an elevation of TNF compared to controls, and there's an elevation in IL-23 in UC and Crohn's, more so with Crohn's versus controls or patients without IBD. So a little bit about this whack-a-mole, right? What are some of the immune responses that we know about? Originally there was the TNF inhibitors, and you can see where that plays a role. There are JAK inhibitors, and that works with those cells. There's vedolizumab, which works more lymphocyte trafficking. There's the S1P modulators, those play a role in the lymph nodes. And then the IL-12/23, just seeing where these are in the gut and how they play a role with the cytokines. So this slide was brought up a little bit earlier in the IBD session. And just to give some context of when I began practicing in 2009, all there really was the anti-TNF. And so we became very good at utilizing, I would say out of all of these medications, the anti-TNF class is what I know the best. I know how to measure it. I know how to manipulate it. I know how to use it. And it took us some time to realize that the TNF pathway is very different from the newer medications. We waited a long time for vedolizumab. That was our first new mechanism of action. And we were waiting on something else, something new with bated breath. We're like, yes, we have something besides TNF. Well, be careful what you wish for, because if you look, suddenly in the 2020, we had an explosion of new mechanism of actions. And it can understandably become so confusing. Which one do I use? How do they work? What's happening? And that's what we're going to go through today is really utilize real world evidence, hopefully to give you some clarity and to make some sense of where do I start? Where do I go with all of these medications? And hold on, because more newer mechanism of action medications are coming. So if you feel like you don't have the brain space, make some if you plan on working in IBD. So again, just a little closer look at IL-12/23. So if you look at, there's an IL-12/23 that share a common subunit. That's the P40 subunit. So when we look at ustekinumab, that's blocking both of those pathways. Well, the newer IL-23, guselkumab, mirikizumab, and risankizumab, they only block the IL-23 pathway. They are only blocking the P19 subunit. So we're looking at a much more directed pathway that we're blocking. Specifically, guselkumab has an even more differentiating factor where the cells that produce IL-23, they also produce this other CD64 target. And CD64 is expressed in inflammation. When a patient has inflammation, they're going to have IL-23, they're going to have CD64. So guselkumab also binds to the P19 subunit, it binds to IL-23, and it also binds to the CD64. The exact clinical implications of this, we're not sure, but that is sort of one way that it differentiates itself among the three IL-23s. So this is going to be the really fun part where we share our different experiences and different decades and different years of practicing. So I'd like to welcome Kim.
Thank you, Elizabeth. All right. So we're going to start with a case. And I feel like after Sharon's great plenary, hopefully everybody, we're not going to be as fancy with the polls, but I am going to ask you guys to raise hands, which will be very hard to see. But as you think about JR, I really want you to challenge and think about in your clinical practice, the patient and patients that you've seen similar to JR. So JR is our 19-year-old male who was recently diagnosed with ulcerative colitis. When he presented, he had at least 8 weeks of symptoms, including 6 to 8 loose stools per day, with more than 50% having blood. He also had associated weight loss and fatigue. When we shift his biomarkers in his labs, his Calpro is 3,000. We see an anemia. Obviously, all of us then hopefully are getting some iron studies to follow, but we're assuming for multiple reasons he is iron deficient anemic. Colonoscopy showed moderate to severe left-sided ulcerative colitis, which matched his moderate to severe, I'd say more towards severe in some ways here, clinical picture. So I'm going to go to the next slide, but first I want to just take a second and think about all the options we've talked about when we think about these ulcerative colitis patients and that shared decision-making of therapies that you could see as a good fit for this moderate to severe ulcerative colitis patient. So I'm going to ask you to just read through these options and then with a show of hand, and I think really importantly, it was so eloquently discussed this morning, and this is why I think all of us find IBD fun. There's not a right or wrong, right? There's a lot of different discussions we can have with our patients, particularly when they are naive in terms of the options for this first therapy. So steroid, TNF with combo therapy with methotrexate, Veto, Usta, or an IL-23, a JAK or CYP. And so just to show of hands, how many of you are going to reach to that steroid for JR? How many of you are going to talk about TNF methotrexate? Okay, we got some hands. Veto, we got some hands. Usta or a 23, we got a lot of hands. JAK, and I want to give everybody this reminder that in the United States, this is a naive patient, and we are not going to jump on label directly to that JAK unless they've not tolerated, lost tolerance, not responded, etc. to ATNF. And then the CYP medications. Anybody leaning towards CYP class here? Okay, we got a few hands. So as was shown earlier, but I really want to recap a few things on this slide, is we have these guidelines from AGA and recommendations. On the left-hand side, one really important part when we think about this patient like JR, I hope we are not thinking about mesalamine. Hence, mesalamine was not an option there, right? Mild to moderate, great option. But this patient is already moderate, more towards severe. So as we can see with this recommendation, we want to think about earlier advanced therapy, knowing that we do not want to step up and put this patient at more risk of complications and surgery, etc. So on the right-hand side, the other thing I want to call out, and it was very well discussed this morning, but again, to reiterate, is that when we look at these guidelines based on network meta-analyses, we are starting to get a lot more help in terms of where we should start to think when we see these naive patients with ulcerative colitis. So when we look at these higher efficacy medications, we can see here it includes infliximab. We're going to talk a little bit more about why infliximab compared to other TNFs. We see Veto, we see our CYPs, both ozanimod and etrasimod. We see UPA, again, though that reminder that in the United States, we have the label and want to hold that for our exposed patients. And then we see 2 of our IL-23s. The other thing I want to reiterate, and I know this was mentioned this morning, but really important, is seeing that adalimumab is a lower efficacy medication, okay? And so when we move to look at that a little bit more, now really important as mentioned, this is not head-to-head. Okay, so I'm just showing you some comparative based on the efficacy outcomes of different studies. As we talked about this morning, not every study is run the same way. The patients going into these studies have different exposures compared to naive. They have different medications they were exposed to. So we unfortunately here are not looking at apples to apples, but it does help us to understand why some of these guidelines are positioning certain therapies higher efficacy and certain therapies lower efficacy. So when we look at the TNF class, for example, we can see that infliximab does have superior endpoints in its clinical study compared to the endpoints of adalimumab and golimumab. So again, why we see adalimumab in that lower efficacy recommendation in the guideline. Again, you can see with the JAK inhibitors that while not a head-to-head, we see greater efficacy with UPA compared to TOFA in ulcerative colitis. And then on the right-hand side, when we look at the 1223 USTA compared to 23, a couple of just general takeaways for the class is we do see greater efficacy with the 23s compared to USTA 1223, and that it is important to see it's pretty comparable when we look at the efficacy class across the 23s. And I do want to point out that the same way we can't say apples to apples, it's really important that we don't just want to look at the endpoints that we're hitting here, meaning not just the 24, the 20, and the 23s. We also want to look at those deltas. And so when these meta-analyses are done, those deltas are how much superior was that drug compared to placebo. The other important thing with this slide is we are here just looking at clinical remission after induction, right? And so we also want to remember, as was spoken to about the STRIDE recommendation, it is not just that upfront how patients do, but also the long-term that we'll talk a little bit more about. So here is another really important part is I just showed you JR. So here's our naive patient. So on the left-hand side, again, similarly, we see greater efficacy in our 23s compared to 1223, again, pointing out different studies. In USTA, that efficacy endpoint was 8 weeks, compared to in the 23s, that first induction efficacy endpoint is 12 weeks. When we flip over to the right-hand side, and again, the studies are not comparable. So there were different percents of patients who were naive versus exposed. There were different exposed therapies. There were varying in the studies of who was exposed to 2 biologics, more than 2 biologics, etc. But in general, what we do see is the IL-23s were at least equal to, if not greater in efficacy in that prior biologic exposed patient. Again, while it is not on this slide, when we also further look out at the 52-week endpoints, we really do see that these are therapies that do not only work in our naive patients, but they are really good options in our exposed patients as well, which we are going to talk about. So before we circle back to JR, just a few reminders when we do think about the classes and the options we have for these naive patients. So when we think about TNFs, a lot of really big pluses, right? We know rapid onset of action. So for those patients that we really need to get better, and we need to get them better fast, and we're like, we want to avoid steroids, we know that it has good rapidity of onset. Complicated disease, patients with extraintestinal manifestations, particularly overlapping rheumatologic and dermatologic conditions. And then as mentioned this morning, we have really good safety data on our TNFs. Of course, on the right-hand side, we want to talk to our patients about this risk benefit, right? So we still want to talk about the risk of infection. We talked a lot, but the reminder about immunogenicity we can see in this class that as we talk about other classes, we do not see as much. The lymphoma and melanoma risk, which again, we see more often when it's combo therapy with TNF, but we still want to remember that with this TNF class and that malignancy risk. When we think about JAKs, again, just a couple of things I'm going to call out, but of course that oral option. Number 2, again, is that rapidity of onset, where we actually have data that within days, patients can start to have a clinical response, not needing to use steroids at all. And then again, we do have good data for peripheral and axial disease. On the right-hand side, just to remember, I know health maintenance, we talked a lot about this. When you do go for that JAK with your patient, just make sure you talk to them about getting the shingles vaccine. Do not hold therapy. They need to go on therapy, but we want to encourage our patients to go and get Shingrix. And then, of course, just making sure you're comfortable having that conversation about oral surveillance and understanding the patient population that was looked at and why we talk about MACE and DVT risk with this class of therapy. And again, as mentioned this morning, that this is not a class of therapy that we're going to use when we're looking at patients who are pregnant or planning on becoming pregnant in the near future. So looking at our 1223, and we've used USTA for so many years, I'm sure many of you still have a lot of patients on USTA. We're not going to say USTA is a bad therapy, but we are starting to see a shift we're going to talk more about from this 12-23 to 23. But the positives, and there's still positives of USTA. We know it's safe. Again, low immunogenicity. We know it has concomitant coverage for psoriasis, psoriatic arthritis. And we do have good data, again, in not just the naive, but that biofailure patient population. On the not as great side, it doesn't work great for those axial spondyloarthropathies. We also know that very often in our clinical practices, we do need to do off-label escalation with this therapy. And then coming to the 23s. So again, safety, low immunogenicity. We know in these therapies, we really do not have any need for adding on immune modulators unless we are specifically looking for coverage of things like the joints with methotrexate, but not for the drug itself. Again, for Riza and Gus, we have also the coverage for the skin, psoriasis, and psoriatic arthritis. And again, it works well, not just in our naive, but our biofailure patient population. We are starting to get long-term data, so we will continue to have more. And what we are thankfully seeing is not just that upfront response with the 23s, but also really good long-term sustainability. Depending on the drug, we're starting to get the 2 to 3 year long-term data. Again, seeing that sustainability of this class. We still want to remember this safety, really safe drug. We saw the safety pyramid. So we know the drugs in the 23s are really sitting up there in the top of the pyramid for safety. But a few things to remember, not surprising, right? Patients can get an injection site reaction, but really remembering while it's quite rare, and I think we should be doing this with every therapy we put a patient on, we want to check their LFTs at baseline. And depending on the drug, the exact time is going to differ. But during induction, we want to make sure that we are repeating those liver functions for the very rare hepatotoxicity that can be seen within this class. So now we're going to go back to JR. So he was started on steroids initially, and I'm sure you've heard this 100 times. While steroids, I don't think is the wrong answer here, we are not using steroids as our maintenance, right? These steroids is a bridge, particularly for those patients. I see a lot of nodding heads, right? Great. We finally have started to see this improve, but the only time we should be doing steroids should be we are doing steroids as a bridge, right? We're doing it to get to the what's next, and we should not be giving those steroids without the plan of what follows. So if you raise your hand for steroids, not wrong, as long as it's to what. And so here we're going to say, well, we had that shared decision making with this patient. There were a lot of class options we could discuss with him, and we decided to transition him over to a 23 or a 12-23. And so which 12-23 or 23 inhibitor do you choose for JR? And kind of what goes into this question of, are we going to USTA? Are we going to Miri? Are we going to Gus? Or are we going to Riza? And again, the class in general, safe, efficacious. So kind of how do we decide? What do we think about? Well, again, a lot of this comes on us as clinicians to discuss with our patients. We all know we hate to think about access, but access matters. The other thing that really matters is some of the patient preference about how do they want to take their therapy. So now as we look to these 23s in ulcerative colitis, they all still have to be infusion based at this time as they initiate therapy. I know on here you can see sub-Q for Gus, reminding you that that is only in Crohn's disease currently for induction, and it is only IV for ulcerative colitis. And so we can see here, but just a few things that we want to discuss with our patients. As you see on the bottom, 3 of these 4 are also approved for psoriasis, psoriatic arthritis. So if patients do have concomitant disease, that might be something to consider. You can see here with Riza, I do want to highlight that while the formulation includes the syringe, pen, and cartridge, in IBD, we are using that on-body injector, the cartridge. So the syringe and pen is in our non-IBD indications. And so really it becomes a discussion of on-body injector. Do you want to do an injection? Are we talking about monthly? Are we talking about every 8 weeks? And again, access, what are we actually going to be able to get this patient on? All right, we're going to transition over. Oop, now I went backwards to Sharon, who's going to give a little bit of a different patient.
Thanks, Kim. So that was a great case, and that was a ulcerative colitis patient who was newly diagnosed. So we're going to switch gears a little bit.
Sharon,
And I'm going to
before we
present.
switch gears, we might just take a moment and talk about, we wanted this to be a little more interactive with the group. And so maybe we can.
I'm going to leave you up there, but I'm going to turf back to you for 1 second. Elizabeth, I'm going to go to you first. So going backwards, and I apologize. Before we chose that IL-23, because I do want to call it the fact that there are a lot of options that I tried to highlight, but I really did want to call on my colleagues. If you would kind of share, Sharon, since you're up there first, going back to JR, that naive ulcerative colitis patient, and we had a lot of options, including veto and the SIPs and all that. Can you just share, and as I ask the audience to think about not just what they would choose, but why, maybe your first thought on that JR patient?
Sure.
I know I put you on the spot at the mic.
So I would put him on an anti-TNF. I would put him on infliximab with or without methotrexate. We know from Sonic combo therapy is better. We can always pull off the methotrexate. The patient's sick. We got to get him better. And I would try not to use any steroids in him. See how quickly I could get the infliximab going with him.
Elizabeth, I'm going to ask you the same question since
Yeah, sure. So when I was at UC San Diego, I didn't see very many newly diagnosed UC, like fresh and shiny. But now that I'm in private practice, I see these patients more. And I see this young man that has decades of inflammatory bowel disease history in front of him. I would start him on steroids. I think that was appropriate. I would also watch his response to steroids. Delay has papers that have a predictive model for vedolizumab. And I think that would be really good. I like to think I would save my big guns and see how he responded to steroids. If he responded well to steroids, he would respond well to vedo, transition him over to sub-Q. And I think that, I mean, as good as you pick one that you like and stick with it and know the side effects, know what to expect, know when you expect a patient to start to feel better, and don't overthink it.
and I'm going to share, and then Sharon, I promise I'm going to give it back to you. As I alluded in here, and I would have really discussed with this patient an IL-23. And so it really would have come down to the access and their preference. And I think the whole point of this is we all see and treat a lot of IBD. And when we see these naive patients, there really isn't a right. So there might be certain ones, as I alluded to, including adalimumab, that I would say is more of a wrong first line, but there's a lot of rights along this class. And I think as we see these patients, it's not just the why am I including these classes in this option to the patient, but really thinking about the why. And again, looking back at that guideline of when it comes to that naive patients, we have a lot of higher efficacy therapies compared to the intermediate and lower efficacy therapies. And then really having that shared decision-making about that patient, their concomitant overlapping extraintestinal manifestations and any other risk factors that they might have. Sorry, Sharon, I promise we're giving it back to you now.
Okay, we're going to move on. Meet our second case. She's a 33-year-old female with Crohn's disease for 10 years. She initially presented with right lower quadrant pain, fever, chills. She had a 10-pound weight loss, nausea, and loss of appetite. She was treated with infliximab every 8 weeks. We don't really know how much, what the dose is, for the past 2 years. However, she tells you when you see her that she was frequently skipping her infusions. And she said she just felt like she was too busy. She didn't have time to go and get the infusions done. And then she also said she really doesn't want to have an infusion type of medication. She also tells you that she is interested in starting a family within the next year. Her labs, so her CRP is 0.8. So that's actually normal. But remember, we have a fair amount of patients that don't mount an elevation in their CRP or sedimentation rate when they are flaring in IBD. Now, her hemoglobin's 9, so you know that something is going on with her. Her CRIT's 26. So again, similar to the other case, and likely iron deficiency anemia, likely because of her disease flare. On colonoscopy, she has a narrowed terminal ileum, and she also underwent an MR enterography that showed 10 centimeters of active inflammation in the TI. Now, we don't know what her prior MRE has been, but 2 years, she's gone to have 10 centimeters of active inflammation. So the question really is now, what would we do with this patient next? So again, show of hands, put her back on an anti-TNF. Perhaps now we have injectables. Anybody put her back on the anti-TNF? Nobody. Okay.
Somebody,
And
somebody.
IL-12/23 or IL-23 inhibitor. Okay. I see more hands there. Would anybody give her a steroid right now? Okay. You guys listen. How about a JAK inhibitor, right? She was already on the anti-TNF. Any people with JAK? Okay. So let me go to my colleagues. Elizabeth.
So I don't like throwing the baby out with the bathwater. She had an original response with infliximab. I would like to draw levels. We know that she skipped doses. It's possible that, again, I'd like to draw levels. I'd like to see if there's room, if she doesn't have antibodies, is there room to increase the dose? Could we recapture her with injectable along with interquart steroid that would affect that inflammation in the TI? That would be my original thought. It would change if she had antibodies, but that would be my first choice.
Okay, Kim.
So I would go with B here. I'm going to go to an IL-23, and I think a couple of reasons, and I don't disagree with Elizabeth. I think again, there's no right or wrong. I think considering adalimumab here is not a bad answer with proactive drug monitoring in a patient who I'm going to presume here likely lost response due to antibodies, since she was unfortunately, like many of our patients, not extremely compliant. But we do have some really good data for 23s even after patients have been exposed to TNF. So I would go with a 23 in this situation. And I know there were no hands for JAK, but I want to make sure everybody remembers that in this case, it's a young patient who mentions she wants to get pregnant soon. And so we want to make sure we are removing that from our options due to her family planning.
Great, thank you. So let's look at some guidelines. These are the ACG guidelines for Crohn's disease from 2025. So at the top, you can see steroids. Okay, we can use them for Crohn's, but only for induction. And again, as Kim says, it's a bridge, which means you have to have the bridge to somewhere. The day you start the steroid is the day you start the advanced therapy. Next up are thiopurines. We don't use thiopurines or methotrexate anymore as monotherapy, but we frequently use it in combination with any of our anti-TNF therapies. Then there's the anti-TNFs, and all the way down, these are all now for induction and maintenance. As I said, we now have sub-Q infliximab. It's maintenance only. Same thing with vedolizumab. We do have a sub-Q dosing in addition to the IV, but the sub-Q is only for maintenance. Kim talked about ustekinumab, and then we can see the anti-IL-23 agents, and we're going to talk a little bit more about that. And then OOP is at the bottom, but remember, people in this country need to fail an anti-TNF first. And again, Kim alluded to the fact that she really wants to get pregnant within the next year. So we wouldn't start this most likely since we sort of have that foreknowledge that she was trying to become pregnant. So looking at the next step is, what about our safety of these advanced therapies in pregnancy? Will that help us to choose? Besides the fact that the JAK inhibitors are not recommended for pregnancy, the other medications that we talked about are generally considered safe in pregnancy. And we have really the data that we have. There doesn't seem to be any issues in mom or baby during mom's pregnancy. So we put her, as Kim says, she was put on ustekinumab, and that was required for insurance coverage, so we couldn't start her right on the IL-23. And after 4 months, though, she had an incomplete response, as evidenced by both patient-reported outcomes or her symptoms, but also looking at elevated biomarkers. Again, she didn't mount the elevation in her CRP, but her calprotectin that we did get in follow-up was still elevated. So with those two, we said, you know what, it's been 4 months. We are not happy with not getting a complete response. So we tried to get what Kim alluded to. What we have done in the past is shorten the interval between her ustekinumab injections. And we tried to do that, but the insurance denied that. So then the question is, well, now can we consider an IL-23 inhibitor? So this slide essentially shows that since ustekinumab was out first before the IL-23s that we're talking about, ustekinumab trial was done with a placebo. But because these are similar molecules, these companies made the comparator arm not necessarily placebo, but they made the comparator arm of ustekinumab, knowing that us clinicians in the field would want that information. Can we go from ustekinumab to the IL-23? Will we see these people respond, or are they too similar a molecule, as Elizabeth presented? So on the left is the VIVID trial for MIRI, and on the right is the results of the Galaxy trial for Gus. And again, you can see the comparator arm is with ustekinumab, and that you can see that the p-value was higher with the IL-23s in terms of this is clinical remission now for all of those medications. So this is the data for risankizumab in terms of the Crohn's disease. Again, they did the same thing. They took patients who failed ustekinumab, like our patient that we're presenting, and looked at, you can see on the bottom right, that 40% of patients were able to achieve steroid-free clinical remission at week 12, so induction, in patients with previous ustekinumab exposure, and then 57% in those patients who actually had a loss of response to ustekinumab. So this was seemingly working in both subgroups of those patients, primary non-response and loss of response. And then this was a very important head-to-head trial for advanced therapies, looking at comparing risankizumab with ustekinumab. Again, this is clinical remission on the left at week 24, and endoscopic remission at week 48. So showing that the RISA was superior to ustekinumab in terms of being not significant in the clinical remission, but endoscopically it did show a clinically significant difference. So now we're left with, there's 3 IL-23s on the market. Which do we consider for our patients? So I'm going to start with Kim.
Again, for me, I don't know that I'd have one that I necessarily want to start with. I'd say a lot of it for me is going to depend on access and where I'm going to go. I'm going to add one thing, Sharon, if you don't mind. I love that you pointed out on the couple slides back, and it'll answer this question after, but in the Vivid study with Miri and in the Galaxy study with Gus, the important part that Sharon alluded to, that we were not just looking at those therapies compared to placebo, but also comparing them to ustekinumab. And while it isn't on this slide, this really alludes to part of my answer, is you showed some data to RIZA, but when we look at the Vivid study with Miri, there was actually a subset of patients who did not hit endoscopic response at the end of a year. And if they stayed in for open label, they had an opportunity to transition over to Miri. And what we actually saw is with both clinical and endoscopic response in those patients, over 50% of patients that had not responded to the ustekinumab arm did respond when they were transitioned over to Miri, right? So again, alluding to your big question of clinical practice, like where do we go to and why? That's one example. I also want to highlight similarly in the Galaxy study, again, which was the IV arm of Gus for Crohn's disease. It was quite a small subset, but they did allow about an N of 17 patients in the study who had a prior exposure. It was not a loss of response or non-response, but a prior exposure to Usta. And we did see similar efficacy in those patients that had prior exposure to Usta, similar to what we saw in the efficacy in Galaxy of the patients who in general just responded to Gus. So that's kind of how I defend I would really argue that I drive this kind of by access and again, the patient preference for dosing, because we have this good opportunity now with 3 studies, again, set up different, but to show us that the 23s do work even in that patient who had exposure to 1223.
And I'm really glad they did these studies, because intuitively, I would not have expected these patients to respond after a UC failure. And I don't pretend to be an immunologist, but the fact that they do share that same subunit, are we really making that significant difference in just blocking the 23? I'm glad they did these studies, because I don't know if I would have made that jump without having that data to support it. Which IL-23 inhibitor would I consider? Again, I think this is very different from our first patient. Our first patient was very young, very new to a diagnosis, probably had never taken medication before. Our patient here, she's had Crohn's disease for 10 years. She's been poked, she's been prodded. She's just a little bit more involved in the healthcare system. If I'm going to throw one out there, I probably like Riz for this patient. I think she could manage the on-body injector. I think just to kind of throw one out there, what kind of patient services are available, what type of insurance, if I had to start with one, again, find one that you can call your MSL, you can call your rep, that you know how to get it covered. Pick one that the backward, forward, how it's dosed, its idiosyncrasies. I kind of think of it as like antibiotics. Remember how we just had to sort of pick one that we liked and know it back and forth. And if that patient's allergic, well, then you go to a different pathway. The point that I want to make is, again, with all of these meds and more coming, don't overthink it. What we want to do is actually decomplicate this for you. And sort of, there's, when we talk to the patient, hey, there's 3 flavors of ice cream. One of them is like this, and one is like this, and one is like this. And, it's really is, some people hate strawberries, some people love chocolate. It's really that sort of simple when you kind of break it down. So I'm going to go with risankizumab for this patient.
Okay.
I'm going to go with vanilla for this patient.
Okay, so we saw similar slides that Kim presented, and that was for patients who had ulcerative colitis. These are slides about the trials for the IL-23 inhibitors, and these are only in Crohn's disease patients. You can see that there is a little bit of a difference, again, comparing the ustekinumab, but also in the IL-23 is that there's a slightly decreased response to those who have failed another biologic previous to this. So we do see higher rates. This is clinical remission at week 12 on the right. We do see higher rates of clinical remission in the bio-naive, and that's pretty typical. And again, as Kim said in her talk, you want to look at the delta to placebo with these as well. So the patient was started on guselkumab. At her 3-month visit, she reports clinical response. But wait, how do we know that she's responding, right? Patient-reported outcomes are great, but we also need to look at some other parameters. So this, there was a great article that was just published a couple months ago. So the reference is on this slide, and you can take a look at it. And the article is all about monitoring disease activity in both Crohn's and ulcerative colitis. And here on the left, you're starting a new medication, and you want to see decrease in disease activity scores. And so patient-reported outcomes, and you want to see a decrease in fecal calprotectin and or CRP. If you have the intestinal ultrasound at your institution, you want to see improvement in that. And that's going to be a response that you want to look for at 6 to 12 weeks after starting therapy. Then the next time would be 3 to 6 months later. You want to also check patient-reported outcomes. Do they have any symptoms? Again, check the fecal calprotectin and or CRP, maybe doing another intestinal ultrasound. And then endoscopically, usually when we start new advanced therapies, we do check endoscopically what things look like anywhere from 6 to 12 months after starting therapy. And we want the endoscopist scores to improve. We also want the fecal calprotectin to improve, CT MRE for Crohn's disease. And then really, if they're doing well, we want to monitor proactively every 6 months. So checking fecal calprotectin, CRP again, and perhaps the intestinal ultrasound. So this just sort of shows you the normal timeline for that. So I'll just throw in another question to my colleagues. Would you change the treatment plan if she had fistulizing disease?
So here I'd have a little bit more of a solid answer. I would probably actually still stick to my 23, but Angelina showed this so nicely. For those of you who were there this morning, we do have some really good data with risankizumab for fistulizing disease. Of course, we still have data also for USTA, but after what Sharon just presented, I'm still favoring the 23s over the 12-23. While we don't have official data yet, I still want to call it again, though. There's some case studies of GUS with fistulizing disease that look really good, and they're also currently studying more on fistulizing disease. But for this one, just because we do have a little bit more data currently for Riza, I'm going to go with Riza, remembering that UPA would be a good option if she wasn't going to start family planning.
Yeah, and I think that's completely appropriate. Realizing she had previously failed infliximab, but there's still adalimumab, which has great data for fistula disease, and Angelina shared that with us too. So, let's not kind of forget about our old school treatment too. Let's not forget.
Right. So when we look at the guidelines, there are 2025 guidelines from ACG for the management of fistulizing Crohn's disease. Again, as my colleagues alluded to, it's the anti-TNFs that have done the most studies. As we heard in the IBD section, infliximab, actually old drug, but it still has the robust information about treating fistulizing disease. And it's not wrong, though, to use some of the other drugs. And on this slide, you can see Vito, USTA, UPA, any of these would be fine for fistulizing disease. And then they talk about antibiotics as well. So in summary, as we can see, the therapeutic landscape for IBD has substantially expanded over the past few decades, providing a large variety of treatment options for our patients. Although the IBD guidelines effectively summarize the science to inform clinical decisions, it's incumbent on the practicing clinician to successfully translate the science to patient care. Guidelines should be used in conjunction with clinical experience and individual patient factors and desires. APPs should now feel empowered to make some treatment decisions for patients with IBD. And we know that maintaining up-to-date knowledge and networking with our GHAPP colleagues can help all of us improve our ability to provide optimal IBD care. And with that, I'd like to open it up to the audience for any questions. We do have some microphones in the center of the room. This will be up as an enduring webcast on our app. Yes. Good question. She asked about the slides. The slides should, maybe they're not in the slide section, but they will be up on in our ACE app and the website. Yes, I see somebody standing. Oh, you have the microphone. Are there any questions?
Yeah. Why was veto not provided as an option for? Why was veto not provided as an option for our last patient with Crohn's? That would be my preferred treatment.
Oh, you mean on our list? Or-
Yeah, on your last patient, the
Just-
Crohn's patient, considering pregnancy.
Yeah,
And then there was on your slide, there was no, veto was not mentioned as far as pregnancy data either.
It could have been. There really isn't any issue. There certainly isn't any issue in pregnancy. Kim, were you going to say something?
no, I was just gonna, very similar to what you said, there's no wrong answer with veto. While Sharon showed that we do have some supporting data for veto with fistulizing, I think it's a good option and it is safe, as Sharon said, in pregnancy. It's not typically where I personally usually go to that often with complicated Crohn's disease. So that would be my like personal answer for that. But to your point, a good option for pregnancy. And we do have some data like the others for fistulizing disease.
Good point out, Dustin. Thank you.
And the thing is that even though people think that it may not be the best choice for ileal disease, we know it's actually quite effective for pouchitis. And what is a pouch? It's the ileum. So again, you're not wrong by choosing that medication, and definitely safe in pregnancy. Any other questions?
Thank you. I just wanted to go back to the case study for JR. I've been doing GI for the last 2 years since I graduated. And one of the biggest conversation that I have in that population with their mom is the male fertility potential. Obviously, I do take into consideration a patient like that, that's 19, probably heading to college, likely to, drink alcohol, other factors. And I try to kind of explain to them that sometimes when we choose these medications, they tend to be for specific reason to hopefully kind of mitigate any potential risk factors or things like that. I know that infliximab was brought in as an option for that patient, but if he looked like fair, sun-kissed, cancer risk is higher on those kind of group for infliximab. If I did think of infusions, I would find it very hard for the patients to attending college or maybe going away or something like that to always be doing injections or probably infusions or, something that I feel like maybe they'll be less compliant. So oral medications in that case seem to make more reasonable sense based on his disease. But obviously, again, if there is a potential for accidental pregnancy, the education is that, there could be some risk associated with that pregnancy, not from him if it was, transmitted the medication through like through the sperm or something like that. Does that kind of conversation happen in the clinics, or do you guys ever address male fertility when it comes to like these biologics?
So I want to take the first part of your question, and with infliximab, there is a sub-Q option available, biosimilar sub-Q option. So absolutely, that's where all of my patients really go. I don't really use Remicade infusions for new starts anymore. They're on infliximab and they switch to the sub-Q. We chose the we chose methotrexate and not azathioprine for him as a male because of the hepatosplenic T-cell lymphoma risk. All patients with IBD should be getting a skin cancer assessment every year, not just on anti-TNFs, but also that risk is there with IL-20, 1223s, they're with ustekinumab. So regardless of your patient, your IBD patient should be getting annual skin checks. So with the methotrexate, we do know that methotrexate carries an inherent risk with female pregnancy. With men, that data is actually a little, it's not as firm because sperm is produced produced more frequently. But do you have information on methotrexate in males?
I mean, obviously there is some data that it can decrease your sperm count while you're on it. So I think it's a good point. You brought up a few good points, but that one, just to have the conversation that there are some studies that show that methotrexate can decrease male sperm count.
I thought she was referring to the S1Ps.
Well, that's what I was going to
Why
get
not
to
use an
S1Ps
S1P?
next.
And there's when we keep saying the risk of pregnancy with S1Ps and JAKs, it's in females. There is no pregnancy risk in males. They're not transmitting any increased risk.
And I will add to that, though, I think you brought up one other point related to the S1Ps is if this was a patient who's going to college and says to you, I'm not going to do an IV or an injectable, I would say a SIP might be a really good option, S1P on that patient. So that goes back to our point of the shared decision-making of where is that patient in life? What are they going to be do? We didn't say for JR, but I think it brings up a great point that maybe you're going to shift more towards an oral option. And in a naive patient, I don't think an S1P would be a bad option. I hope that answered all the parts to your question.
And honestly, when we were developing this case, I wasn't thinking of fertility in a 19-year-old male. But again, that is, in certain populations, certain cultures, that's absolutely, it's not necessarily a question we want to not ask in our population.
Are there any other questions? Yes.
So what I find difficult is the insurance is like the biggest obstacle, frankly. Do you guys have any tips on like when you do prescribe the ILs, you include something extra? Do you have any tips on that?
So is it the IL-23s in particular? Is
Yeah,
it?
like let's
Yeah.
say it's a treatment naive patient and I want to do an IL-23. Like, is there anything that you write extra in your note to get better coverage? Is there any tricks like that?
I mean, you can include the guidelines, a copy of guidelines. You can attach a lot of different documentation, and guidelines can be helpful. Most of the times they're not because they don't really care about guidelines. They care about the money, right? So it's there aren't a lot of great tricks, except keep fighting for your patient. I mean, if you get the denial, I mean, everything goes to a prior auth. And then when you get the denial, you have to fight the denial and fight it very quickly. And that's where the denial letters help. And the Crohn's and Colitis Foundation has the structured what goes in a denial letter. And then you can have all the attachments with that as well. So it does take extra time, but our patients are worth fighting for.
And I don't know if I'd make a patient wait to go through the denial process. I wouldn't be that attached to one particular drug. I would say know which drugs have patient support access that can get your patient drug quicker than others. I wouldn't be that attached to make a patient wait because they want one particular IL-23.
Yeah, right. So it depends on what's in your denial letter. So you have to read that very carefully and then fight what that statement is. Because sometimes it's a class. You can't use it, so you need to use something else. But yes, to Elizabeth's point, that's why you have to know what's in the denial letter. And then if we're just saying you wanted to put them on an IL-23, you would just try another one and go from there.
Thank you.
Any other questions? I think we're running out of time. We'll be available for any other questions. So I want to thank the audience very much.